Hello, everyone. Welcome to our Growing Healthier Facebook Live program. I'm Sherry with the CGH Health Foundation, and Growing Healthier is an educational series that's sponsored by the Health Foundation. And we try to educate you about important health topics, and it also gives us an opportunity to introduce you to some of our excellent providers. And today's program features one of our new providers in sleep medicine, and that is Dr. Brittany Monceau. And Dr. Bird is going to be talking to Dr. Monceau about sleep and how the quality of sleep affects our life physically, mentally, safety, etc. And the CGH Health Foundation has a lot of initiatives and ways that we try to help our community to live healthier lives. And those initiatives and projects are funded by our donors. And we have some fundraisers throughout the year as well. And so I wanted to tell you about our spring fundraiser, which is an auction, a virtual auction. And it started this morning. It opened this morning. We have 180 baskets and desserts and experiences that you can take a look at and bid on, and the money will go to fund our programs. And if you're somebody who likes to see the items up close and personal and live and in person, we are going to have a little open house on Monday night here at the Health Foundation offices. We're at 2600 North Locust Street in Sterling, and our open house will be from 4 to 7 on Monday. So stop out and take a look. And might be able to get a cookie or something like that too while you're here. Before I turn it over to Dr. Bird and his conversation with Dr. Monceau, I just want to let you know what next month's program is. And we will have Dr. Warren Cannell, who is a longtime CGH pediatrician. He's going to be coming on and talking about immunizations and vaccinations and why they are so important. And that program is going to air on June 5th, on Thursday, June 5th at 12 noon here on Facebook Live. And now I think I'm ready to turn it over to Dr. Bird so he can talk to Dr. Monceau. Are you ready, Dr. Bird?
Yeah, I'd say so. Hey, Sherry.
Hello.
Hey, a follow up on that auction. So it's happening now.
It is happening now. It is a virtual, so there's actually a link that you go and look at all of the items, and you can bid using that link on their website too. And I think we're going to put the link in the comments so it's an easy way for people to access it.
I should know this, but when does it end?
Tuesday night at 8 p.m.
Okay, so people that come to the open house, can they bid when they're there? Is that kind of the plan?
Or no? If they have their phone and click on the link, yes, absolutely.
Okay, so it's more of an open house just to kind of look around and say hi to everybody more than it is to.
Yeah, and also to say thank you. I know we'll have a lot of people who donated baskets there, and our donors are awesome. You will not believe some of the items that they've given us. So
yeah, okay, got it. Okay, I just wanted to clarify that. So okay, thanks, Sherry. Yes, I think welcome to the show from me. I'm Bill Bird, Chief Medical Officer here at CGH Medical Center, and today we are going to talk about sleep, and I'm looking forward to talking with one of our new physicians, Dr. Brittany Monceau, and I have some questions for her about all things sleep. So without further ado, here she is. Hi, Dr. Monceau. Welcome.
Good to be here.
Okay. All right. As I usually do, particularly for folks who are new to our viewers, new to our area, I wanted just to give you a moment just to tell us a little bit about yourself.
Okay. Well, I was born and raised in Louisiana, particularly like South Louisiana. And then I went to college up northern part of Louisiana at Louisiana Tech University. That's where I met my husband. And afterwards, we went to Shreveport to LSU Health Sciences Center, and I went to med school there. I did a psychiatry residency and then followed up with a sleep medicine fellowship. I worked there for a little bit as a sleep medicine physician, taught some fellows, had them graduate. I don't have any kids, but we do have like 3 pets, mainly because my husband won't let me get any more.
Okay. Yeah, good. Thanks for that. So you're actually a psychiatrist as well as a sleep medicine doc.
Mm-hmm.
I'm just curious, what made you, since you're basically you could do either or. What made you decided you want to go in the direction of the sleep medicine?
So there was a couple different things. One of the things like during my psychiatry residency that I saw a lot of was like a lot of the conditions we treated had a lot to do with sleep, but it wasn't always addressed very well.
Okay.
Sometimes we'd be like, well, if they're having trouble sleeping, we'll put them on a more sedating medication. Um, but it was more of the mentality, well, once they get better, the sleep will just resolve itself. And that's not always the case. And you can see like patients really struggling with their like mental conditions, like people with drug addictions will like relapse, and a lot of it could be due to poor sleep. So
Yeah.
then I have a lot of people in my family with sleep problems.
Okay, there you go. Well, that makes sense. And by the way, for folks who are watching this live, if you have any questions for Dr. Monceau, feel free to send those our way and we'll try our best to answer them. So speaking of sleep, let's talk about that a little bit. Tell us a little bit about why sleep is important and what do we know about the benefits of getting good sleep?
So yeah, sleep is super important. I mean, otherwise you wouldn't be spending so much time during your day having to do it. So like what we know so far is one of the main theories is kind of the lymphatic system in your brain will help clear out the waste products from the day. So like as you're expending energy, things are breaking down, those products will build up in your system. So it's kind of like a little bit of a reboot. And also like it helps with memory consolidation, learning. You'll see it like your growth hormone in kids, that's when it's being produced. It helps regulate like a bunch of other hormones like your insulin. So you'll see a bunch of people like if they work night shifts, they'll tend to eat like carby food and be more at risk for like weight gain and all that kind of stuff. It can affect your heart, and then like memory, concentration, all that will be affected. And also like when you're like sleep deprived, you'll see a lot of problems with like mood regulation, and then like heart disease, all sorts of. There's still a lot we don't know, but
yeah,
it pretty much affects everything.
Yeah. That whole reboot example and the lymphatic drainage thing, that wasn't part of the thinking when I started my career. So I think that is definitely something that makes a lot of sense. But it hasn't been always that's how we thought about sleep.
No, it's more of a newer thought process, and they're even like looking in like Alzheimer's disease and like beta amyloid, and that's one of the things that sleep helps clear out.
Yeah. Yeah. Okay. So let's talk a little bit of just specifics from your perspective, from what you know. How much sleep is enough sleep?
So it really depends on your age. When you're an infant, so like 4 to 11 months, get about 12 to 15 hours of sleep for the 24-hour period. So that's including naps. Toddlers, so 1 to 2 years, about 11 to 14 hours, including naps. The preschoolers, so about 3 to 5, that's 10 to 13 hours.
Okay.
I believe usually after about 5, people kind of stop napping. Kind of regret not having naps during the day. So children, once they're in school from like 6 to 13 years old, they're supposed to be getting like 9 to 11 hours. And then teenagers need to get like 8 to 10 hours. And once you become an adult, you get to the 7 to 9 hours and the typical more 8 hours that you hear of a lot. And then once you get older, like 65 and older, usually they do like 7 to 8 hours. So a lot of times I'll come across some children that are more on adult sleep schedules, and it's like trying to remind people, yeah, children do need more sleep. Their brain is forming, is processing, pruning, all the different things.
Yeah.
The memory.
That makes sense. So one of the things that prevents us from getting the proper amount of sleep, and let's just say also, it's not just the time, but it's also the quality of sleep, the sleep apnea, biggie. I'm sure you do a lot of work with people with sleep apnea. Can you kind of walk through for us, number one, what are the types of sleep apnea? And what does sleep look like for patients who experience each of those types of sleep apnea?
Okay. Yeah, so there's two main types of sleep apnea that we talk about. The first one is obstructive sleep apnea. That's usually when someone says sleep apnea, what they're referring to.
Okay.
That is whenever like your airway is being blocked off during sleep. So when you're sleeping, your body's kind of relaxed. Like your tongue can fall back. If you have some extra weight, it can push on your airway and cause it to collapse. And it's kind of like being choked in by your own body while you sleep. So usually people that are experiencing that, is snoring is probably the main thing that people will complain of. And that's a lot of times happening because like the airway is falling back, and when you're trying to breathe, the air is trying to get through, so it's causing what's blocking you to vibrate and make that noise. So a lot of times patients, they'll, like a spouse, a significant other will be complaining about their snoring. They'll be woken up into sleep like, hey, stop snoring, move over. They also will, sometimes spouse or significant other will see them stop breathing. So they'll be like snoring, that, and then sometimes that will cause them to wake up gasping or choking in their sleep. You can wake up with morning headaches because you're not getting oxygen to the brain at night. A lot of times you'll be sleepy during the day. They can also experience like sleep maintenance issues because it's waking them up throughout the night. We've also seen with like increase in nocturia, like they'll have to use the bathroom more frequently. You also see that as a big one in like children, like wetting the bed can be associated with sleep apnea in children. A lot of times you'll also, when they come in, like they'll tell you, oh, I can't sleep flat. I prefer sleeping in the recliner. Or they'll be sleeping on their stomach. And that's a lot to try to keep the airway from collapsing, and they just naturally go to that.
Okay. Good. And then what's the second type of sleep apnea you mentioned too?
Yeah, the other one is central sleep apnea. So it's different. So instead of your airway collapsing, the airway's open. It's just your body is not telling itself to breathe. Usually we see that as more like a secondary symptom to a medical condition.
Okay.
Or like medications, opiates can cause that. Like people who have strokes can get it, or other neurological conditions. It's really big in like heart failure and AFib. A lot of what's happening during that is, since your blood is not pumping very well, the little receptors that kind of tell your body whether or not you have enough oxygen or enough, like what your CO2 levels, and monitors that. Since there's delay in time when it gets that information, it will get like information like, oh no, there's too much CO2, start breathing that out. And then so the person's breathing out their CO2, but they overdo it. Because by the time the blood gets there to say, oh, you've done it, and then you overdone it, the body then says, oh, stop breathing. Get this back and cycle. And they just kind of run that through. That one's a little bit harder to really like symptoms wise. because they don't necessarily snore, they can. So if someone sees them stop breathing, sometimes they'll wake up with headaches. They don't know why. They'll be sleepy during the day.
Mm.
But a lot of times it's more like they have a medical condition and you're
Yeah.
for it.
Okay. Yeah, that makes sense. So it's more of your in your brain, that part of your brain that automatically tells you to breathe isn't working right.
Yeah.
Yeah. Okay. What percentage of folks are that versus the obstructive sleep apnea, would you say?
Ooh.
Ballpark.
Oh, goodness. I hate to put out numbers. I would say most of them, a good, probably at least 80%. A lot of people with central do have obstructive too.
I see. Because we can have a mixed picture for some people.
Yeah.
Got it. Okay. Good. So let's talk about what you can do about it. Just rattle off as best you can. What are the medications, surgeries, medical equipment options for people, particularly people that have the obstructive sleep apnea? What would you say some of those medicines, surgeries, other device options are, and how effective they are in those type of things, Brittany?
So the main treatment option for actually both obstructive and central is the positive airway pressure. We have different types of it, like CPAP or BiPAP, and it's kind of the gold standard. It works really well for both of those conditions. On the machines, you can actually monitor how much people use it, how well it's being controlled. So that way, you know, if the machine isn't working well, they might need a different type of device. So that's the main one, is the one that insurance tends to pay more for. So it's what people are kind of, whenever they think about sleep apnea, that's what they imagine, is the mask with the machine blowing air in.
Mm-hmm.
And it's good for like mild all the way to severe sleep apnea.
Okay.
The other option is they do have like mandibular advancement devices. So it's like an oral appliance. You would go to a dentist and they would like do like mouth fitting, and it will help kind of pull the jaw forward.
Okay.
I believe it was recently kind of cleared for severe sleep apnea, but for the most cases, we tend to leave it for more mild to moderate sleep apnea. Doesn't help with centrals.
Yeah.
The other main one is the one that's probably got so many commercials out now, is the Inspire device, which is a hypoglossal nerve stimulator.
Okay.
And usually to get that one, you have to fail CPAP. They also have a bunch of different criteria that you have to kind of check off to get it. And what that does is a little device that gets implanted, like right around here. It's a day surgery. It has a lead that goes up, and whenever you're sleeping, you turn it on, and it kind of sticks your tongue forward.
Okay. You get okay. I would think like that would cramp your tongue up.
I've had people on it, and a lot of people really like it.
Okay.
You can adjust the voltage. So they make you go through like this range, and the person has voltage options, and you kind of go up as you're tolerating it.
Yeah.
And then once you get to a point that you've kind of maxed out, you think it's working really well, they have you come back in for like a fine tuning where like the tech would have control over it, and they'll see how many events you're having and kind of
that makes sense.
Pressure.
One other quick question, going back to the commonest thing, and that is the CPAP or BiPAP. How do you troubleshoot for patients? Because you hear it all the time. I've heard it where they didn't tolerate the CPAP. How do you troubleshoot for patients who are struggling to tolerate those machines?
So, it really kind of depends on what the issue they're having is. A lot of times, if it's a mass, sometimes like a smaller mass size, people tend to get those really big ones at first, and those are huge and annoying, and they come up on the bridge of your nose, and they'll be rubbing the bridge of the nose, and like air will escape. So trying to figure out what was going on that made it hard to tolerate, and then trying to troubleshoot towards that. So a lot of it is actually mask and mask leaking or it being uncomfortable. And luckily that they've come up with several different mask options now.
Okay.
Another thing is like if they're having issues with breathing out against the machine, the CPAPs do have something called like expiratory pressure relief. So it will drop the pressure whenever it senses them breathing out. But sometimes that's not enough, and they may need something like a bi-level that has the two pressures whenever you're breathing in and then whenever you're breathing out, and that's more comfortable for them. And there's some people that just can't tolerate anything on their face. Sometimes you can let them know to try to desensitize themselves. So put the mask on while they're like distracted watching TV or something, and see if they can get used to it that way. But then if they're still having a lot of issues, then usually you go to some of the other.
Yeah, then the other options kick in. Yeah.
But I found that a lot of people, they just kind of get given the machine and no one really troubleshoots anything with them. So, and that tends to be a big problem.
Yeah. And that's why you're here.
Yeah.
To troubleshoot, right?
Yeah.
Right. I want to talk about one of the time we have left, one other type of sleep issue that, is pretty common, and that's restless leg syndrome. Can you talk a little bit about that? What is that, and what do people experience who have that?
So with restless legs, that one's a interesting thing because it's kind of very complicated and it gets mixed in with so many other conditions and can get really confusing trying to pick it out from like arthritis or neuropathy and all of that. Yeah. Usually for restless legs, there's actually a mnemonic you can kind of go by. It's URGE. So the U stands for urge. They'll have the urge to move the legs. Usually it's accompanied by an uncomfortable feeling.
Okay.
And then the R is for rest. It happens mainly when they're resting, particularly trying to go to sleep at night. And then the G is for like getting up and moving. That usually helps like either partially relieve it or completely relieve it as long as they keep staying moving.
Okay.
That one tends to be one of the more like to help differentiate it from other symptoms, other conditions. And then the E is for like evening worsening. So it does have more of a circadian rhythm to it. So it usually will start during the evening time, but as it like progresses and gets worse and worse, it can like start getting up earlier into the day. And unfortunately, some of the medications can cause augmentation, and that could also make it happen earlier in the day. But usually the current thought on it now is that it's due to like low iron levels and affecting dopamine in the brain. So like iron is a big part of like making dopamine, is one of like the cofactors. And if you don't have enough, you can't make it. So that's why we usually, when people present with that, get a ferritin level. And we like to see it at least 75, which is a little different because the normal range, where I used to work, it was 22 to 300, but here I think it's more like 14 to like 280 for the reference range. So it's a lot, like they can still be normal in the normal range, but not enough to help with the treatment of restless legs.
Okay, interesting. So it's some type of iron and how that causes dopamine production in your brain, which then can lead to this restless leg issue.
That's what the thinking is kind of right now, but they're also thinking there might be something else going on because they have found some patients that doesn't seem to be the case for.
Yeah.
But that was like
more to come, but at least that's the latest information on it.
Yeah.
Yeah. So like obviously then you're going to treat some of your patients with some sort of iron supplementation. Beyond that, how else do you try to help folks who have restless leg, Brittany?
So besides the iron, you definitely want to make sure they avoid any like triggers. So like antihistamines can make it worse. Um, Alcohol makes it worse. You definitely don't want to be sleep deprived. That will also make it worse. Some things you can't really avoid, like if you're on antidepressants, that can also make that worse. But for like medication options, there was like a recent switch in the like what should go first. So right now it's the alpha delta ligand, so like your gabapentin, your pregabalin
Okay.
medication. So that's the first line. It used to be the dopamine agonist, like the propranolol, the Maripex.
Yeah.
So what they found with those medications is the longer people were on them, they call it augmentation. Their symptoms started getting worse. So they would notice that you kept on having to increase the dosage over and over again. And they'll start having symptoms like earlier in the day, instead of it just being in the legs, now it's in the arms. And it turns out like the medication is now causing it.
Okay.
You can still use them, but usually they don't want you to do it first line anymore.
Okay.
Because of the risk.
Okay.
And then like if kind of all else is failing, there's like different low dose opiates you can use.
Okay. So it goes Neurantins of the world, gabapentins of the world.
Yeah.
And then the Mirapexes, which when I was particularly when I was younger and in practice, we use that a lot.
Mm-hmm.
And then it goes to like an opioid potentially to help folks. Okay.
Yeah.
All right. Good to know.
And you gotta be careful with the dopamine agonist, because like the max dose is different than compared to like what you would treat for Parkinson's disease.
Yeah, absolutely.
It's a lot lower.
Right. We're getting close to our time, but I did want to ask you just a couple more questions. There's home sleep studies and there's hospital-based sleep studies. How do you help when you talk with patients and kind of go through that process with them? How do you decide which one they would benefit from?
So usually the first thought process is, what am I trying to find out about? If it's just like straight obstructive sleep apnea, if I'm not concerned about like them acting out their dreams or doing anything else, then if they are having something else like that, that needs to be an in-lab. The home sleep studies, at least the ones right now, are just mainly for obstructive sleep apnea.
Okay.
And then after that, the home sleep studies do tend to underestimate the severity of sleep apnea.
Okay.
So it'd be more of the patients I would lean towards that I would consider like a higher risk of being like a moderate to severe sleep apnea. So they are presenting with a lot of the symptoms of sleep apnea.
Okay.
If it's more like they might have sleep apnea, but it'll probably be mild, you probably want to do an in-lab. You can always proceed to an in-lab if the home sleep study doesn't show anything.
Yeah.
Then after that, usually we want healthier people. So if they have like COPD, heart failure, personally, if you had a stroke and stuff like that, I would prefer you to do an in-lab. But ultimately, kind of try to leave it up to the patient, because they know how they'll respond to all this stuff on their head on the in-lab.
Yeah.
And like I said, we can always bring them in if that comes back negative. And then after that, it kind of depends on the insurance and what they'll agree to.
Yeah, there's that piece too, for sure.
Yeah.
I also just wanted to cover for folks who may not be aware of this. My understanding is that you see not just adults, but children too. Is that right? And kind of what ages do you see, Dr. Munsell?
So right now, I'll see ages 5 and up.
Okay. Okay. All right. Well, I think that's good to know. I don't know that that's not something that we have typically done here at CGH, is to have patients under 18 that we would see. So that's great that you're able to do that. So just want folks to be aware of that. And the other thing, as we wrap up here, like, how would someone go about if they thought, they're hearing this conversation and they're like, either they think they might have it, or they go, hey, I know that my significant other has this, or one of my family members or friends does. How does someone go about making an appointment to see you or your nurse practitioner, Rebecca Cady, for potentially having one of these sleep-related conditions?
Okay. Yeah, they can call the main clinic line at 815.
Oh, there it is.
Well, there it is. And then they can ask for sleep medicine, and we'll be happy to get them scheduled. As far as I know, you don't need like a referral from a doctor. You can self-refer.
Yeah. And also you can see that Dr. Monceau sees patients both here in Sterling as well as in Dixon. So there's a couple options for you in terms of getting into to be seen. So, okay. Well, hey, great information. Thank you for taking the time just to talk through some of these things with us, Dr. Monceau. And it's great to have you here at CGH.
Yeah. Well, thank you for having me.
All right. Take care.
Bye.
All right. I thank you, Dr. Monceau. Did a very nice job there. It's great to have her. I wanted to share a couple slides here before we let you go. Carmen Sage was our recently minted Employee of the Month for May. She works in our medication refill department. And so congratulations to her. So wanted to make sure we give a shout out to her. And as we mentioned, as Sherry mentioned at the beginning of our broadcast, Dr. Cannell will be with us next month, and actually pretty soon, next month, to talk about childhood and adult immunizations, which I think is a very timely topic to be talking about. So looking forward to having Dr. Cannell here with us. Once again, thank you for taking the time to watch this, and of course, share this with others if you thought it was helpful. Until next time, have a great day. This is Bill Bird, Chief Medical Officer here at CGH Medical Center.